Moral Right to Healthcare. Elizabeth Wales, HCA 322, Healthcare Ethics and Medical Law, December 16, 2014. Sanson, 2013, writes, in Code of Ethics in Healthcare, Virtues versus Rules. The moral demands of the healthcare professions called for a code of ethics around which the professionals could learn how to act as the kind of moral being they should be in the practice of their particular work. The codes did not and do not now create the moral demands of the professions. They express the profession's compelling moral forces. Codes of ethics should codify necessary requirements for practitioners to carry on the continual learning, wisdom, and skill of a profession that is not reducible to a set of abstract perceptive rules. They must express what has been learned in the maturation of a profession designed to help patients overcome their illnesses, maintain their health, and come close as possible to live out a natural course of life. The code should become clarions for vocational integrity rather than merely safeguards against mistakes, legal challenges, and social opprobrium. Among the many ethical theories and principles, 4 concepts are used specifically to help guide healthcare. These are known as the bioethical principles: autonomy, beneficence, justice, and non-malfeasance. Bioethical principles. Autonomy. The principle which requires that the patient is given full control of the medical situation and, as long as the patient is mentally stable, makes all decisions for medical care. Beneficence. The principle which requires healthcare providers to do good for patients. Justice. The principle which guides medical personnel to treat patients with fairness. Non-malfeasance. The principle which requires that no harm is done by medical personnel. Autonomy, beneficence, justice, and non-malfeasance encourage healthcare facilities to provide medical help to as many individuals as possible, but the moral right to healthcare is limited by resource availability, fraud and abuse of healthcare budget, medical malpractice, cultural competency, and privacy concerns. Resource availability is a primary struggle with regards to providing health care to wide demographics of individuals. When handling the hospital's budget, we are juggling items which require millions of dollars. The financing of our facility has to be carefully calculated in order to be efficient, or we will not be able to keep our doors open. Our facility is only one of many which struggle with resource allocation. Many healthcare facilities are under pressure with regards to how resources are distributed, as extra staff is a requirement due to the growing, aging population, putting budgets under increasing strain, creating a time of unprecedented financial pressure. Bustillos 2013 states in Healthcare Ethics and Medical Law, justice is a fundamental principle for healthcare administrators and practitioners, particularly in their responsibility to make resource allocation decisions. Healthcare administrators have a duty to craft resource allocation policies and procedures that maximize the chances of fair and equitable treatment. This is a difficult task, but as Dennis and Hurst 2009 suggest, in developing the capacity of ethics consultants to promote just resource allocation, there are several components a hospital's committee may utilize to help make the most efficient use of their limited resources. First, the mission of the hospital must be clarified and finances prioritized accordingly. Second, routinely held meetings which identify the resource limitations which the providers encounter on a regular basis must be scheduled to ensure the budget is current with facility needs. Finally, this process must be ongoing to reduce mismatches between assigned resources and needs. This formula will help ensure ethical, efficient resource allocation, and, when managed with care, the moral right of medical staff to provide health care to individuals may be done with less inhibitions. The ability to provide health care to individuals is limited by abuse and fraud of health care dollars. Every year, $80 billion is lost to medical abuse and fraud of federal resources. Brustilios 2013, Section 7.2. One way which abuse and fraud occurs is through physician self-referrals, which often results in unnecessary testing and expense for the patients and is motivated by financial benefits for the physician. The Stark Law was designed to control unnecessary tests and treatments ordered by physicians who may benefit financially from the referral. The controlling of self-referrals not only helps control unnecessary testing, but it also helps regulate pricing within the medical field, as prices must remain competitive. There are 3 phases which the Stark Law accomplishes the regulation of self-referrals. Phase 1, established in 1992, restricts Medicare program laboratory self-referrals. Phase 2, established in 1994, restricts additional health services for both Medicare and Medicaid. Phase 3, established in 2007, clarifies exceptions and reduces health care regulatory burden through interpretation. With regulations to help prevent abuse of funds, the 17.9% of the United States GPD, World Bank Group 2014, which the United States spends on health care, will stretch much further and to those who sincerely need the medical funds. Individuals' moral right to health care is dependent on the health care being maintained at a decent level of quality. Unfortunately, malpractice has been on the rise since 1975. To help counter the rise of medical malpractice, many regulations have been placed in the medical field to help prevent the circumstances which result in malpractice. Brustilios 2013 states in Healthcare Ethics and Medical Law, many organizations promulgate codes of conduct and professional standards to which their members should adhere in an effort to assure the public of the quality of their health care. For example, the American Nurses Association has established Code of Nursing Conduct as well as professional standards for member nurses. American Nurses Association 2013. Guidelines like these are important not only as public statements of minimal thresholds of quality, safety, and ethical care, but also because they help inform the thresholds of legal negligence and the malpractice of professional liability contexts. Failure to comply with professional standards and guidelines for safe practice may stand a compelling evidence of a healthcare professional's or healthcare organization's breach of duty. Elders 2006 documents in his academic journal article, The Politics of Healthcare. We have too few minority health professionals. Minorities constitute 27% of the population, and only 12% minority healthcare professionals. The 2 primary reasons this is a concern is that first, as the article Why Diversity Matters in the Health Professions 2010 puts it, ethnic diversity is associated with improved access to health care for racial and ethnic minority patients, greater patient choice and satisfaction. Second, this also reveals that minorities are not provided with sufficient opportunities to enter the healthcare field. In the article Executive Summary, the Committee on Quality of Healthcare in America, 2001, emphasizes the importance of minority doctors. Minorities are more likely to see healthcare providers if their providers are of the same ethnicity. Because there is such a low percentage of minority providers, many individuals in minority groups do not utilize healthcare system to have their health needs properly attended to. This self-segregation decreases the chances of successful treatment from providers, as minorities often neglect seeking help until their conditions have progressed too far. This is another aspect to consider in regards to providing the ethical rights of health care. In our facility, providing cultural background education to our staff is a concern of no small matter. Brustilios 2013 lists 3 main principles for cultural competence in healthcare ethics and medical law. 1. Acknowledgement of the importance and prevalence of culture in people's lives. 2. Respect for culture differences, and 3. Minimize of negative consequences arising from cultural differences. In matters regarding a medical character, information is of an extremely personal nature. In order for individuals to disclose sensitive issues to medical personnel, individuals must feel assured that this information will not be misused. Individuals must believe that the discussions between them and their medical team are private, and that those whom the information is disclosed to are trustworthy and discreet. It is for this reason that HIPAA contains privacy rules for patients and protected health information. The National Nurse 2011 emphasizes the privacy rule protects all individual identifiable health information held or transmitted by a covered entity or its business associates in any form of media, whether electronic, paper, or oral. Page 23. This high standard of medical practice allows patients to seek help for physical and mental health from professionals in the medical field. Without confidentiality standards in the healthcare field, many personal ailments would be hidden from the medical personnel for fear of unauthorized disclosure of sensitive information. This is another way which our hospitals' ethics make a difference in regards to providing health care to individuals. Autonomy, beneficence, justice, and non-malfeasance encourage healthcare facilities to provide medical help to as many individuals as possible. But the moral right to health care is limited by resource availability, fraud and abuse of healthcare budget, medical malpractice, cultural competency, and privacy concerns. By providing these aspects within our facility, we can accomplish more and fulfill the need for health care to a greater extent.